So I presented results at the AAD meeting on another study called JADE regimen, which was another study for moderate to severe atopic dermatitis patients. The design of this study is actually unique. There are no other study designs in the moderate to severe atopic dermatitis space that has this particular has these particular design elements. And importantly, the study was designed to look at what happens when you start off with high dose drug and you have a response, and then you have to decide what to do with the dose of that drug, either to continue the same dose, to lower it, or to put, or whether to take the patient off. So first of all, the drug. So in this case, the drug we studied was called Abrocitinib. Abrocitinib is a JAK1 inhibitor. It's an oral blocker of JAK1, which is involved in pro-inflammatory pathways, in particular pathways involved in atopic dermatitis pathogenesis. And this drug had previously been shown to be effective in moderate to severe atopic dermatitis patients in pivotal phase 3 trials. And the doses that were studied previously were 100 milligrams a day and 200 milligrams a day. So going back to the design of JADE regimen, in this trial, we gave all patients 200 milligrams a day of drug for 12 weeks. So essentially the high dose, the most effective dose for 12 weeks. And then we asked the question, did they respond or not? And about 65% of patients achieved an IGA 0/1 and EZ75 response, which we labeled as a responder. And so the other 35% of the patients actually were dropped from the study at that point and were not continued on because it was not the purpose to look at those patients anymore. Again, the purpose is to take responders and then with maintenance therapy, check different things, different doses to see how well they do with maintenance over time. So a third of the patients that were responders stayed on 200 milligrams, a third went to 100 milligrams, half the dose, and a third were put to placebo. And then the patients were followed from week 12 to week 52. So 40 weeks of follow-up on those 3 different maintenance doses to see what happens, to see if they flared. So the interesting result is that I first like to talk about the 2 extremes of the data. So the extreme patients that were really challenging were the 200 milligram patients who stayed on 200 milligrams, but 19% of them had atopic dermatitis flares, even though they continued on high dose. So I call that the really tough population, the more severe patients. Despite staying on the high dose, they had flare, and it was about 19%. On the other end of the spectrum, really interesting, really fascinating, what I call the super responders. And those are the people that were on 200, they responded, and we put them to placebo, took off drug, and 19% of them did not flare. So actually, 81% of patients, they flared, they needed drug, and the disease came back pretty quickly. The majority of patients within 1 month of stopping this pill, they had disease coming back. But that curious population, kind of the extreme, some patients did not require continual drug. Again, 19% going to placebo. And then if we look at the intermediate group, the ones who are on 100 milligrams, actually the majority of them did not flare. It was about 56% did well. So 81% did well on 200, 56% did well on 100, and 19% did well on placebo. So the bottom line for the efficacy for preventing flares is, yes, the 200 milligram dose is the best. 100 milligrams is the next best, and then placebo is the worst. But on an individual level, and if you're in private practice and you're using this drug and you treat high dose for 3 months, you're going to have options. And this study gives practitioners the data they need to understand that not every patient's going to need continued high dose. The other important piece, which I haven't mentioned yet, is safety. And with JAK inhibitors, we do see a number of possible safety issues. And we did see that in the study. Common things were acne, elevation of CPK, drops in platelets that weren't dramatic, but some drop in platelet counts. So these are things that we see with JAK inhibitors, and we saw them more commonly with 200 milligrams than we did with 100 milligrams. So another caveat is if you are concerned about safety or seeing safety issues with the higher dose, you would be expected to see fewer safety concerns at the lower dose, which is what we saw in the study.